Good morning, everybody. Today, yesterday we had hospital management. Today we are going to have a case management, that is how to look for the patients for the COVID-19, their clinical features, their clinical syndrome, and how to manage them. So today the sessions will be on the case management. We'll have Dr. Bindu Matthew from St. John's College of Nursing. She's a professor and deputy nursing superintendent of St. John's College of Nursing. So she will be explaining you about the clinical features of the patients. So over to Dr. Bindu Matthew.
A very pleasant morning to the IC team. Once again, I thank all of you for this opportunity given to me. Today, we are going to discuss regarding the case management of COVID-19 patients in relation to nursing perspectives. So, the learning outcomes of this particular session is to describe the clinical features, the clinical syndrome classification, screening and triaging of patients with COVID-19, discuss the management of COVID-19 patients with mild and moderate symptoms, including nursing management. Looking at the clinical features, as we all know, COVID-19 may present with mild, moderate, and severe illness. When we speak about mild, moderate, and severe illness, it depends on the stage where the patient is. Like, say, for example, the viral response in the initial stage is stage 1, that is the early infection. And in the stage 2, when there is a pulmonary involvement, it is starting with hypoxia, and which leads to stage 3, which is ARDS, that is hyperinflammatory response. So this COVID-19 infection, depending on which stage the patient is, it can cause acute respiratory infection. Mild disease, mild form is common symptoms like that of fever, cough, sore throat, fatigue, and myalgia. But when the patient goes into a severe form, it will include severe pneumonia, acute respiratory distress syndrome, and sepsis and septic shock. That is what when it was discovered in Wuhan, it was only, we got a cohort of patients who had symptoms like pneumonia, and that's from where we were able to trace and find out that it was a COVID-19 infection. So severe illness, when you have severe illness, you will have severe acute respiratory infection symptoms, like, say, for example, breathing difficulty, because hypoxia is so important in COVID-19. And when you see patients with hypoxia, you should understand that the patient is progressing to a severe form of disease. That's why while we take care of a patient, it is always better that we have a finger pulse oximeter with us, so that every nurse who is caring for these patients will be able to identify hypoxia at an early stage, so that we can prevent the patient from going into a need for ventilation. Early recognition of these suspected patients will allow us in timely initiation of IPC, that is infection prevention and control. It's very important that we initiate IPC in the beginning itself, because today in our scenario, few of the studies have shown that people have started hiding the history. And because of hiding history, then the healthcare personnel, now we know our majority of the healthcare personnel are getting into infection because people have started hiding history. So therefore, early recognition of these suspected patients is important, so that from the beginning itself, we can initiate IPC measures. Early identification of severe manifestations will help in immediate supportive care management, safe and rapid admission to ICU. Because if you look at the scenario, we know that 30% of the patients may not have symptoms. 55% may have mild symptoms, and 10% of the patients may require ICU admission, and 5% will be with mechanical ventilation. But the most important thing for us to understand is that once the patient progresses to the severe form, that is that 5% who requires ICU admission with mechanical ventilation, many factors come into play. That is, if they have comorbidities, they will be at high risk. Or even from this 5%, 50% of the patients have shown to have mortality. So of the 5%. So therefore, it is very important, as we are talking about the nursing care, it's important for nurses to identify those symptoms which will be the highlights that it tells us the patient is progressing into a severe stage, so we can prevent high mortality. Now coming to uncomplicated, when we talk about clinical syndromes in COVID-19, in the initial slide, we mentioned that there can be mild to severe symptoms. So the milder part, that is the early infection, where there is just a viral response, initial viral response, the patient may be in an uncomplicated illness stage. When you say uncomplicated illness stage, the patient will have milder symptoms like fever, fatigue, cough, anorexia, malaise, sore throat or muscle pain, etc. That's what we said, myalgia. Patient may also have dyspnea because of slight, oxygen depletion that is happening to the person, and nasal congestion or headache. That is just flu-like symptoms, or mild flu-like symptoms that the patient may have. Rarely, patients may also present with diarrhea, nausea, and vomiting. Why? Because of the inflammatory response that is happening within the body to limit the viral infection. The elderly and the immunosuppressed may present with atypical symptoms also. So this is in uncomplicated illness, and majority of the patients who come to us with this may be in the initial response to the viral infection. Now, when you talk about this clinical syndrome, mild pneumonia conditions are important in this COVID-19 patients. That is, in adults with pneumonia, but there won't be signs of severe pneumonia and no need for supplemental oxygen. So the patients can be kept without oxygen supply. Patient can be just managed for the milder symptoms that the patient is having. Children, but remember, even if that is the case, IPC measures the nurses will have to undertake, and they have to be careful while handling these kind of patients. Children with non-severe pneumonia who have cough or difficulty breathing and fast breathing, like this fast breathing will depend upon the age of the child. Say for example, if it is less than 2 months of age, the breathing may be more than 60. 2 to 11 months, you may see even more than 50, and 1 to 5 years, more than or equal to 40, and no sign of severe pneumonia. This is how the child may present to us with, that is in case of a mild pneumonia stage. Severe pneumonia, that is something which is alarming for us. We have to be very careful about this. That is, severe pneumonia can progress to even mortality. So when we talk about severe pneumonia, in case of adult or adolescent, they will present with fever with a respiratory rate more than 30 breaths per minute, severe respiratory distress, or SpO2 less than 90% on room air. Here, something very important is that if the person has less than 90% of SpO2, it means that the person is going into severe form of the disease. Whereas if it is 90 to 94, we could say that it is only a moderate clinical syndrome that the patient is going through. So therefore, the nurse, as a nurse, we are able to identify that alarming stage of the patient. So in an adult or adolescent, if it is less than 90% of SpO2 on room air, it is an alarm sign for us. A child with cough or difficulty in breathing, with central cyanosis or an SpO2 less than 90%, severe respiratory distress, sign of pneumonia with a general danger sign, that is inability to breastfeed or drink, lethargy, unconsciousness, or convulsions in the child. This is as a result of even hypoxia, where there is decreased oxygen supply. Also, the person can go into convulsions or seizures. Other signs of pneumonia also may be present in a child, that is, which is something very common in a pneumonia child, that is chest indrawing, fast breathing, that is, for again age-wise it is important, less than 2 months. If it is more than or equal to 60, between 2 to 11 months, more than or equal to 50, and 1 to 5 years child, more than or equal to 40. So as nurses, we should know these, because vital signs monitoring, oxygen saturation monitoring is one of the important responsibility of the nurse. So it's important for us to see the trend of change in these signs for our children or adolescent or adult, so that we will be able to take preventive steps to prevent the mortality. Coming to something very important, that is acute respiratory distress syndrome. That is something very alarming for us, and something which we really need to take care. When do you say that this person has gone into acute respiratory distress syndrome? Is when the person has already gone into the hyperinflammatory response stage. And that hyperinflammatory response stage is called as the stage 3. And that is that ARDS stage. When a patient has got new or worsening respiratory symptoms within 1 week of the clinical insult, then we say that this is an ARDS response. Decreased activity, dizziness, decreased urine output. This means that perfusion to the vital organs is diminished. That's why the person will manifest with decreased urine output. Increasing breathing difficulty, cyanosis, bloody sputum, chest pain, noisy breathing. Again, these are all indications of impaired gas exchange in the patient, because with ARDS, the person will have impaired gas exchange. Severe hypoxic state, that's why the cyanosis you are seeing, and patient may go in for pulmonary edema, wherein you will see bloody sputum, and patient will have chest pain because of lack of decreased cardiac output, and the patient is not getting enough of perfusion even to the heart. Confusion, lethargy, coma, weakness, and seizures. Again, depleted oxygen to the central nervous system can lead to these kind of symptoms. Persistent high fever and other symptoms beyond will be without signs of resolution. That is, so these signs will tell us that the person has gone into an acute respiratory distress syndrome, and this is very dangerous stage. Children may also present with poor feeding, excessive diarrhea and vomiting. Again, diarrhea and vomiting, again, that is as a result of the inflammatory response to limit the viral infection. The person may have such responses or symptoms. Respiratory failure in children, and oxygenation guidelines for mild, moderate, and severe ARDS in adults and children, non-invasive ventilation and invasive ventilation. But remember, non-invasive ventilation is preferred than invasive ventilation unless until you know that without invasive ventilation the child cannot survive, because an invasive ventilation again is at a risk for aerosol generating procedure. So therefore we always try to prevent going into that particular stage. So non-invasive ventilation may be tried out, and also we can see high flow oxygen can be tried out in the beginning for these kind of patients. Coming to clinical syndrome, another very important clinical syndrome. Once the patient goes into this stage 3, that is ARDS stage and the hyperinflammatory response, one thing that can happen with the decreased perfusion to the vital organs is also sepsis, which is a life-threatening organ dysfunction, because with ARDS, patients will move on to multi-organ dysfunction, and sepsis is one important thing that we need to be alarmed about. In adults, some things that we can find in a sepsis stage is, and it is life-threatening situation, altered mental status, difficult or fast breathing, low saturation of oxygen, reduced urine output, fast heart rate. These are all symptoms as a result of low cardiac output and decreased oxygen supply to the vital organs. Patients may have cold extremities, weak and steady pulse, low blood pressure, skin mottling, and lab evidence of coagulopathy. Again, coagulopathy, thrombocytopenia, acidosis, and high lactate or hyperbilirubinemia is an important thing that will indicate to us that patient has gone into sepsis. That is why the ABG value is very important. We need to identify that whether the patient is going into these kind of problems. Now, D-dimer test is also another thing which will tell us that if the patient has got any coagulopathy. So these are some things depending upon the facilities and the infrastructures that are available in the respective ICUs. This patient can be monitored with these for finding out whether patient has gone into sepsis. For children, for suspected or proven infection, more than 2 systemic inflammatory response syndrome criteria. Here, patient, but one must definitely be abnormal temperature or depending on the white blood cell count. So therefore, in adults as well as in children, what is important is that definitely you should have at least 2 criteria or more than 2 criteria of the systemic inflammatory response. But definitely the temperature hike is also an important criteria for children with sepsis. Now, septic shock. In adults, persisting hypotension despite the volume resuscitation will require vasopressors. We know that when person is having a septic shock, we know that we need to perfuse the individual. We need to give volume, the intravascular volume has to be taken care when patient is in a septic shock. So therefore, even by giving a volume resuscitation, if the patient is still having hypotension, then we need to think about providing the patient with vasopressors. Children, hypotension, altered mental status, bradycardia and tachycardia. Bradycardia and tachycardia is a compensatory mechanism. to take care of this particular septic shock. Prolonged capillary refill, tachypnea, increased lactate levels, oliguria, and hypo or hypothermia. Similar symptoms as a result of decreased perfusion. So these are all, when you look at this, these are all some things a nurse is able to pick up while she's taking care of a patient. That is why this is discussed in detail in our case management topic. Screening and triage, very, very important. That is, screen and isolate all patients with suspected COVID-19 at first point of contact with the healthcare system. That is why in our institutions, we have got a screening area or a pre-screening area to just with the history to identify who is a suspect patient. So there, the nurses also play an important role in this particular stage. So the nurse should be able to correctly identify with the history collection who are those patients who could be a suspect COVID-19. They may be asymptomatic. We know that in the initial stage, they may come to us as asymptomatic, although they may be having the infection in them. So at that first point itself, we should be smart enough to identify, and then, at this, we need to isolate them. Classify the patients as per the clinical syndromes and triage them. Now, in our previous slides, we looked at some of the clinical syndromes, mild to severe clinical syndromes. So if nurses having that knowledge of what is mild, what is moderate, and what is severe, I think we will be able to classify and see who has to go to ICU, who may require a ventilation, or who has to go to just the COVID designated cohort or the single isolation area. So this is at the screening and the triage, one of the responsibility of the nurse to identify correctly and triage the patients correctly. Now, we need to know about low risk, high risk patients in screening and triage, and also those who are at high risk. Say low risk patients. For low risk patients are maybe the patients who are coming without having any symptoms. Though for them, those low risk patients, we need to just, maybe they may be just coming to us with the symptoms of the respiratory infections. But we may not have very much clue as to that they may be a suspect or they may be a contact patient. So they are low risk. For them, we can just initiate IPC measures, educate and provide supportive treatment, and they can be sent home with adequate awareness, because one of the responsibility of the nurse is to give them awareness on what are the symptoms they need to monitor and what they should be alarmed about. Second group that we need to know is about the high risk patients. So high risk patients are those who could be a probable COVID-19 infected patient, who may be the ones who have had a contact with the COVID-19 patients. When we talk about patients, we also need to discuss about people, the healthcare personnel also, those who have taken care of the COVID-19 patients, because we know that today many of the healthcare personnel are getting this infection. So therefore, we need to correctly identify who are those high risk patients. Then based on the syndromes that they are having, we need to optimize the supportive treatment. Safe and rapid referral to the designated hospital, ward, or intensive care unit according to the protocol. Older people with comorbidities, as we all know that they have high risk. So therefore, even with a mild symptom, sometimes they may deteriorate very fast. Therefore, for these patients, close monitoring is very, very important. So at the screening and the triage area, it's a nurse's responsibility to correctly identify who has to go where, depending upon the category of high risk or the low risk. So we spoke about high risk and low risk. So let us look at, say, patient having fever or history of fever with cough and an epidemiologic link. When we say epidemiologic link, again, I don't want to repeat what I said in my previous slide, that is regarding those who are suspected or those who have had a contact, etc., or those who have those specific histories which we collect, like travel history and so on. So if they come to us with an uncomplicated, just flu-like or influenza-like symptoms, and if you feel that they are at low risk, you need not worry. They are low risk patients. You can discharge them home with the instructions to return when they have to come. If what symptoms, if worsens or if they fail to improve, we can tell them to come back and they can be sent home. So who are the high risk patients? If at all they have influenza-like symptoms, but we know that they are high risk, they may be probably COVID infected or they are contacts, they are high risk patients. Even the comorbidity like elderly and other high-risk groups, you may need to have them for hospitalization for the close monitoring. Now, next thing that we need to know is severe acute respiratory infection complications. Those are if for the last 10 days, if they have these symptoms of respiratory infections, then they have something like the severe manifestations of hypoxia and other things which you feel that may progress into a severe ARDS, you need to consider hospitalization, and if we need to consider ICU if they are critically ill. That means they are not able to maintain their saturation, and if you feel that they need support measures, they need to be considered for ICU. Treat them with supportive care, antibiotics, enroll in clinical trial if there is any researches that are going on for investigational therapeutics. Now, antibiotics, why? Because sometimes today in the COVID scenario, we may just think about only the COVID, but there could be patients who are coming with other infections which could lead to respiratory infections. So that's why appropriate antibiotic therapy may have to be given depending upon the cause for the pneumonia or depending upon the organism that has infected this particular patient. Now, we spoke about IPC. I think in the previous webinars also a lot of discussions were there regarding IPC. But few things to remember, some of the points you may feel is an overlap, but just to emphasize on some of the important points when we talk about nursing care, in a facility, if you have to implement IPC, infection prevention and control, it is one of the critical and the integral part of clinical management of patients. It must start at the point of entry of the patient to the hospital. That means when your patient comes to the triage itself, the nurse should remember to institute this IPC in the facility. All patients should wear a triple layer surgical mask. Direct the suspect patients to the separate area. Keep 1 meter distance between the patients. Instruct the patients to cover the nose and mouth during sneezing, coughing, and also the cough etiquette need to be demonstrated or taught to them. Perform hand hygiene after contact with the respiratory secretions. So this was discussed earlier, so I'm not going into depth of this again. Apply droplet precautions while caring for the patients. Use contact precautions to prevent direct to indirect transmission from contact with the contaminated surfaces. Here I would like to stress that, these organisms can survive on the surfaces. And surviving on the surfaces will depend upon the type of the surfaces on which this particular organism has fallen. So therefore, it's important to initiate contact precautions so that we prevent the transmission from the contaminated surfaces. And that's why disinfecting with 1% hypochlorite everywhere is so important. Apply airborne precautions when performing an aerosol generating procedure. I think we had discussed this in our PPE class. What are all the aerosol generating procedures? So whenever we need to initiate such procedures, we should be double careful with all the PPE, and then we have to maintain the distance, and we need to take care not to get contracted with the droplets. Components of the PPE was discussed in the PPE class. Again, goggles, face shield, mask, gloves, coveralls or the gowns with or without aprons, head cover and the shoe cover. These are the important components of PPE. It's very important as we are discussing about the nursing care. I would also like to stress that you may have different cadres of nurses that are available in the hospital. So therefore, at different levels, at the manager level, the team leader level, it is important to ensure that we have sufficient PPE, and not only ensuring that we have sufficient PPE, we have to see rational use of PPE and ration the PPE, because you cannot afford to have a PPE wasted at this scenario, because we may land into very much shortage of PPE, and there you may have many healthcare personnel contracted with COVID-19. So it's important at the managerial level to look at the ensuring rationalizing, rationing the PPE, as well as monitoring adherence to the PPE. This is one point I wanted to stress here in the nursing care, because monitoring adherence is very important. Then doffing is important, we said, because while doffing, if you do not do the procedure properly, you can definitely give infection to the others by putting your virus into the contaminated surfaces. So rational use of PPE, some tables like, say for example, if it is in a triage area, what are the activities that is happening in triage area? Triaging patients, provide a triple layer mask to the patient, because the risk involved in the triage area is a moderate risk that is involved. So the recommended PPE in this particular situation is an N95 mask and a gloves. So here the patient also will get a mask. Looking at the screening area or the help desk or the registration counter, the activity that happens is providing information to the patients. So the risk involved over here is a moderate risk. So the recommended PPE for this is N95 mask and the gloves. Temperature recording station, the activity that happens is recording temperature with a handheld thermal recorder. So the risk involved is only moderate risk. So the recommended PPE here is N95 as well as the gloves. Now in the holding area or in the waiting area, the activity that may happen is the nurses or other paramedicals or other people, healthcare personnel may be interacting with the patients. So the risk involved is just moderate risk. So N95 mask and gloves will be enough. But what we need to remember over here is although we are restricting attenders, we may have at least one attender with the patient, and even the patients 1 or 2 may be there. So it's important that we emphasize on the social distancing that needs to be maintained. So these are all responsibilities of the nurse. Nurse need to oversee this. Now, in the doctor's chamber, the activity is just clinical management, where you may have doctors or nurses. The risk involved is moderate risk, and recommended PPE is N95 mask and gloves. So here there is no aerosol generating procedure to be allowed, because we know if an aerosol generating procedure has to be done, it should be done in a separate isolation room, or it should be done in the negative pressure room. So that's important. Now, sanitary staff or the housekeeping staff, the activity is cleaning frequently touched surfaces, floors, cleaning the linen, etc. Moderate risk involved. They will require just an N95 mask or the gloves. Next is visitors accompanying young children and the elderly, because we cannot restrict them. The reason is that because they will need support when they have to navigate to different service areas. So the low risk is involved, and triple layer surgical mask will be enough. Actually, no other visitor should be allowed. Visitor restricting is one of the important responsibilities in this COVID scenario. But still, if there is a requirement, keep this in mind. Individual isolation, rational use of PPE in an individual isolation room or a cohorted isolation room, there the clinical management happens. So when the clinic, wherever there is clinical management is happening, although we say that it is a moderate risk where we need to have N95 mask and the gloves, patients should have mask. And we need to, here in this situation, the patient is stable. We are not doing any aerosol generating procedure here. If it is required, we will have to move the patient to a specific room for aerosol generating activity. But as nurses, what we need to remember is during the clinical management, based on the risk that is involved, the PPE use should be considered. In ICU, both in critical care, both for the critical care management as well as for dead body packing, full complement of the PPE is required. Because in ICU, you may definitely perform a procedure at a high risk for healthcare personnel. Even dead body transport to the mortuary. I think Madam Punita will be dealing in detail about the dead body care. But then just to remind you that the low risk, it is a low risk while transporting to the mortuary, a triple layer medical mask will be enough. But during the autopsy and other things, I think ma'am will detail you in the future classes. So in sanitation, again, I think that point was already discussed. That is moderate risk involved in N95 mask and gloves. Other non-COVID treatment areas of the hospital, there is attending to infectious and non-infectious patients. Risk should be as per the profile of the patients. PPE should be as per the hospital infection control practices. And for the caretaker who is accompanying the patient, it is a low risk, and triple layer surgical mask would be enough. Now coming to another very important thing, that is about the laboratory diagnosis, which is very important for initiating the treatment. So while we know that while transporting this or while collecting the specimen, we need to be very, very careful. So Ministry of Health and Family Welfare, as per their directive, the Government of India, all suspected cases are to be reported to district and state surveillance officers. This is the first thing that all nurses and all healthcare personnel should know. So who should be tested? That is, all symptomatic patients, individuals who have undertaken an international travel in the last 14 days need to be tested. All symptomatic contacts of the laboratory confirmed cases, they also need to be tested. All symptomatic healthcare workers need to be tested. All hospitalized patients with severe acute respiratory illness also need to be tested. Asymptomatic direct and high risk contacts of the confirmed case should be tested once between day 5 and 14. This is important, of coming in contact with that particular person. So we as nurses should know who are the people who need to be tested. Otherwise, there will be unnecessary wastage of testing kits. So we need to know who has to go for the testing. Sample collection. It's a high risk. Therefore, we need to know how the sample should be collected and transported. So the preferred sample for this COVID-19 is throat and the nasal swab in viral transport media and transported on ice. The alternate sample is nasopharyngeal swab. Later on, we will be telling you upper respiratory and the lower respiratory tract samples that we are collecting. So the alternate sample other than this is nasopharyngeal swab, the BAL culture, and a BAL sample or the endotracheal aspirate, which has to be mixed with the viral transport medium and transported on the ice. Respiratory specimen collection methods. The first one is lower respiratory tract. That is by the BAL, broncho-alveolar lavage, or a tracheal aspirate on the sputum is lower respiratory tract sample. Collect about 2 to 3 ml into a sterile, leak-proof screw cap sputum collection cup or a sterile dry container by maintaining 4 degrees centigrade temperature. We will be telling that in our future slides, and because it has to be transported in ice. Upper respiratory tract sample is nothing but the nasopharyngeal swab and the oropharyngeal swab. Here, while taking this swab, sometimes in some of the facilities, nurses are also taking the samples. So therefore, it is important that you should touch the floor of the nasopharynx while you are collecting the sample. So this point, the nurse has to remember. If you do not collect the sample properly, you may get false negatives. So therefore, collecting the correct sample is important in nursing. So collection, when you look at blood also may be collected. This is also a sample for serological examination to diagnose the COVID-19. Because we know that complete blood cell count for white blood cells is important. We know this is an inflammatory response that the patient is going through. So therefore, the blood cell count is also important. Then sputum should be sent for bacteriology. Like say, for example, we know that the persons with COVID-19 present with respiratory symptoms. So this respiratory symptoms may not be only COVID-19. There may be other illnesses also. So therefore, TB also we need to keep in mind. So therefore, including TB in high prevalence country, we need to look at sputum for bacteriology or fungus if the patients are immunocompromised. We may have an HIV patient also because they are immunocompromised. You know, we need to also look at this kind of sputum bacteriology, thinking or keeping these points in mind. Collect the blood cultures for bacteria that causes pneumonia and sepsis, because pneumonia may not be just because of COVID-19. There could be other reasons for patient having pneumonia. But remember, the blood culture should be collected before initiating antimicrobial therapy, and this the nurses should know. Do not delay antimicrobial therapy to collect the blood cultures. That means the nurses has to be proactive and they have to see that quickly the blood culture is collected, and immediately they should see that the doctors will initiate the antimicrobial therapy and it has to be started soon so that you can prevent mortality for the patients. Now, collection of specimens for COVID-19 positive patients, repeat the upper respiratory tract and the lower respiratory tract samples, which should be collected to demonstrate viral clearance, because that is why we do the repeat samples, to know how much of viral clearance has happened from the patient. The frequency of specimen collection will depend on the local epidemic characteristics and the resources, because sometimes we may not have adequate resources. If there is an influx of many patients who are coming, there may not be a possibility of repeating it just to know the viral clearance. So these will depend upon the availability of the resources. For hospital discharge, in a clinically recovered patient, 2 negative tests at least 24 hours apart is recommended. This is important because this is something which has to go into the discharge policy of these patients. So therefore, a nurse should know that this a patient for hospital discharge, at least 2 negative tests should be there with 24 hours apart. Then only the patient is fit for discharge. General guidelines that you need to keep in mind while collecting the specimen is that first one, trained healthcare professionals must wear appropriate PPE with the latex-free purple nitrile gloves while collecting the sample. And we have to maintain the proper infection control measures. Restricted entry to the visitors or the attendants. For anything for that matter, not only collection of specimen, we need to see that in COVID scenario, restriction of visitors is one important point. When collecting the upper respiratory tract samples, use viral swabs, which may be sterile Dacron or rayon and not cotton, and viral transport medium. Do not sample the nostrils or the tonsils. That's what I said, when you collect this, you need to sample from the floor of the nasopharynx. In suspected cases with pneumonia, upper respiratory tract and lower respiratory tract samples are recommended. Collection of specimens, when you say sputum induction, should be avoided due to increased risk of aerosol transmission. Because we know that in TB, we had spoken and we have learned about sputum induction, which should not be done in this particular scenario, thinking about the risk of transmission through the droplets. Dual infections with other respiratory viral and bacterial infections have been found with COVID-19 patients. Hence, do not exclude the possibility of COVID-19 if other tests are positive. You should always keep in mind that even if you feel that it is related to something else, you should always go in for COVID-19 also, because COVID-19 also represents with the respiratory symptoms. Complete the requisition form. Clear-cut information on the requisition form is important. Complete filling, it should not be incomplete. Every detail should be filled properly as per the guidelines. Proper disposal of all the waste that is generated at the time of collection of specimens is another responsibility of the nurse. Now coming to just looking at in which sequence and how the sample has to be collected, packed and transported. The first point to remember is sample vials and the virus transport medium. First one, you have to keep that ready. Second is what you need to keep ready is absorbent material, that is cotton or a tissue paper, paraffin or scissor or a sellotape. The third thing that you need to keep in mind is a leak-proof secondary container. In my next slide, I will be telling you what is the use of each of these items. You need to have a Ziploc pouch, cryo box, 50 ml centrifuge tube, and a plastic container. The fourth thing that you need to have is a hard frozen gel pack, which will be required for us to maintain that 4-degree temperature. Then a suitable outer container, which may be a thermocol box, it could be an ice box, or it could be a cardboard, but dimension is important over here, that is 10 into 10 into 10. So the first thing that you should follow is before collecting the sample, you need to use the PPE while handling the specimen as well as before collecting the sample. After collecting the sample, what you need to do is you have to seal the neck of the sample vial using a parafilm. And the third thing is cover the sample vials using the absorbent material. Fourth is to arrange primary container or the vial in the secondary container. The primary container is the one where we have collected the swab. So that has to be kept into the secondary container. Place a centrifuge tube inside a Ziploc pouch. Then we need to place a Ziploc pouch inside a sturdy plastic container and seal the neck of the container. You can see how much of protection is there for that specimen that we are collecting. The seventh one is, now after you have sealed it in the first and the second one, and you have sealed the cover of that particular sturdy plastic container, you need to keep it in a thermocol box as an outer container and place a secondary container within it, surrounded by the gel packs or the ice gel packs, so that the temperature can be maintained. Placing the completed specimen referral form. So you have secured the specimen what you have collected, but now it is important to identify whose specimen it is, because we know that it is transported and it is going elsewhere for its diagnosis. So therefore, correct information of the patient is important so that you don't create any confusion. And we know that there is a lot of stigma associated with it, fear associated with it. Therefore, if there is a small change that is happening, that can be very hazardous to the patient and the family members. So place the completed specimen referral form, and that is available on this particular website, that is niv.co.in, and request letter inside the leak-proof Ziploc pouch. Another leak, you can see in the picture that outside the thermocol box they are fixing it on, isn't it? So secure the Ziploc pouch with the specimen referral form on the outer container. So these are, some things which we need to really keep in mind, because every step has to be followed appropriately, and that is important, so that the specimen reaches correctly, and also it is important that we are getting the correct result for the correct patient. So that is important. Next is to attach the labels. In that label, what all should be there? That is the sender's address, the contact number, consignee's address or the contact number, and biological substance, where you need to write it as biological substance category B UN3373, orientation label, and handle it with care. This much should be there in the label, where outside the thermocol cover. So these are the steps to be followed while you prepare your specimen for transport to the lab. Some of the documents that need to accompany along with its specimen is, because we know we do not know the resources or the facilities that are available in different states or different places. So sometimes it may have to go very far. So the documents that need to accompany is, first one is the packaging list or the pro forma invoice. Second is the airway bill. If it is to be taken or transported through flight, we should have airway bill to be prepared by the sender or by the shipper. Then the value, that is equivalence document for the road or the rail or the sea transport, depending upon how you are transporting the specimen. A vaccine carrier or ice box can also be used as an outer container if you do not have that thermocol box what you have. The minimum dimension, keep in mind, as I said, that is length into width into height, that is 10 into 10 into 10. This has to be kept in mind. Now, after we have looked at the screening, the triage, and the collection and transport of specimen, something important is management, the nursing management when you have a mild COVID-19 patient. You have a mild COVID-19 patient, you may not require a hospital intervention, but isolation may be required to contain the virus transmission. So every details about isolation, what precautions to be followed when they are in isolation, what to be monitored when they are in isolation, and when they need to seek medical help, what are the alarming signs and symptoms that need to bring them to the hospital should be explained to them. Symptomatic treatment could be given to them. Maybe they may have mild flu-like symptoms or mild fever, etc. You could give an antipyretics for the fever. Counsel the patients with mild COVID-19. That is important. Because of stigma or anything, they should not, that should not prevent them from coming to the hospital and seeking the medical help. So therefore, counseling them is very important. Why counseling is important here is because there will be a lot of fear for this particular patient, because there are a lot of fake news in the social media, and here and there, the patients may get really worried. So therefore, at this stage itself, they may be worried that they have, COVID-19. They may get a COVID-19. They may be isolated from their relatives. All these fear may be there in them. So they may not come back. So therefore, counseling these patients with mild COVID-19 is important. There are no specific medications for the COVID-19 that we need to tell them. Now, supportive measures while monitoring for severe, patients. That is, severe are the ones, as we discussed earlier, those who will require hospital admission. So these patients need to be admitted, give supplemental oxygen therapy immediately to the patients who have got the severe acute respiratory illness and respiratory distress. So we know that they are going to be in a hypoxemia stage or a shock. So the target is to have more than 94% of oxygen saturation. Patients may need airway management. Usually the oxygen that is given is 6 liters per hour. 6 liters, and then the patient on the flow of 6 liters, and the patient's target is to maintain more than 94% of oxygen saturation. Health facilities should be equipped with the pulse oximeters. That's what I said you should have in our PPE class also. We had said that, designated to each patient, it is nice to have an equipment, but here we may not be able to have 1,500 costing handheld pulse oximeters. So but it is nice to have this with the nurses, so that the nurses will be able to monitor the oxygen saturation of the patients. Functioning oxygen system should be there. Disposable single-use oxygen delivering interfaces should be there, available for the patients in that COVID designated areas. Understand the patient's comorbid conditions to tailor the management of critical illness. We know very well, one of the important thing to monitor is those who are hypertensive, those who are on AC inhibitors, etc. Those maybe an elderly who is hypertensive. For them, it is so important because, you know, QT prolongation is one of the risk that they may have, or even these patients are at high risk for going into mortality. So therefore, we need to really identify what are the comorbid conditions so that we can customize and be careful while we initiate any care for these patients. Use conservative fluid management in patients with SARI when there is no evidence of shock, because sometimes this fluid management, if it is not given properly, not given with care by monitoring the CVP of the patients, what can happen is that you can cause pulmonary edema also for the patient. So it's important to remember about conservative fluid management for patients with this respiratory illness. Another thing that is important for us is about the biomedical waste management in the isolation wards. So healthcare facilities having isolation wards for COVID-19 patients need to follow few steps. First one is to keep separate color-coded bins or bags or containers in the wards and maintain proper segregation of waste as per the biomedical waste management rules. This is important because here we say there are guidelines that are given by the government on what we need to keep in mind while we are doing the waste management. That is based on common biomedical waste treatment and the disposable facility for all the using double liners, etc. There are many things that are being told. So as a precaution, we need to have double layered bags. Using 2 bags in the bin should be used for collection of waste from the COVID-19 isolation wards to ensure adequate strength and there is no leak from it. Collect and store the biomedical waste separately. Use a dedicated collection bin and it should be labeled as COVID-19, and it should be kept separately in a temporary storage room prior to handing over to the staff of the common biomedical waste treatment and disposal facility, that is CBWTF. Waste collected in isolation wards can also be lifted directly from the ward to the CBWTF collection van. The bags or the containers that are used for collecting the biomedical waste from COVID-19 wards should be labeled as COVID-19 waste. General waste not having contamination should be disposed of as solid waste as per the biomedical state waste management rules in 2016. Maintain separate record of waste generated from the COVID-19 in the isolation wards. Use dedicated trolleys and the collection bins, a label of COVID-19 waste to be pasted on these items also. The inner and the outer surface of the containers or the bins or the trolleys used for storage of waste should be disinfected with 1% sodium hypochlorite solution daily. Why are we discussing this point? There may be the waste handlers who are coming to us. There may be a supervisor or whoever responsible for this collection of the waste, etc. Those people need to be educated, and that's the responsibility of the nurses. Unless until the nurses are aware of this, we will not be able to educate them. Depute dedicated sanitation workers separately for the biomedical waste and general solid waste so that the waste can be collected and transferred timely to temporary waste storage area. So the nursing care, when you look at for the COVID patients, apply timely, effective and safe supportive nursing care interventions immediately. Provide nursing care to bring down fever and reduce the respiratory and other symptoms. Communicate proactively with patients and families and provide support and prognostic information. Allay the fear and anxiety among the patients and family and provide counseling as appropriate. Educate the patient and the family regarding infection prevention and control in a health facility, in a home and the public. Understand the patient's values and preferences regarding life-sustaining interventions. This is something very important. As we take care of patients in the ICU, or those who are on ventilator, and those whom we know the prognosis is very poor, it's important that whether they have any preference for do not resuscitate orders, it's important for us to know that. So we need to, while we communicate, we should be able to identify this, and the nurse will be able to do this better than anybody else. So closely monitor patients with the respiratory illness for signs of clinical deterioration, such as rapidly progressing respiratory failure and sepsis. How do you identify this? This I have explained earlier. While you monitor your patients during the continuous monitoring, when you feel that the patient is deteriorating and going into a hypoxic state, you will be able to get it as an alarm that the patient is not doing good. Arrange for prompt referral and rapid and safe admission to ICU. This is when you have the patient in the non-ICU area, and when you feel that there is an early warning score, you need to immediately inform and do the prompt measures so that the patient can be taken care in the ICU at the earliest. So the role of the nurses will be, as we have all discussed, in every scenario, the role of nurse is as a caregiver. Of course, we do the responsibility as a caregiver here, although I think there is lot that is coming in the media, appreciating the nurses and the doctors. I'm very happy to see that. Yesterday also I saw something in the media where everybody is appreciating the nurses, that in this scenario, putting the life at risk, we are giving care to the patients. We are caregivers, we are doing all our responsibilities, dear nurses, but remember, while we do the care, we need to remember our health also. So put on the PPE when you are giving the care. We are forgetting our families also, and then staying back for many days and giving care to our patients. So definitely, even in COVID-19, caregiver role is very much applicable. As a case manager, that's why we discussed today's session on case management. That is depending upon whether high risk or the low risk or whatever it may be, whether the patient is in a severe or mild or moderate situation, we are, as nurses, are equipped and enabled to take care of the patient. So we play the role of a case manager, a communicator. Where do we play the role as a communicator? Communicator is, in the inpatient facility, while we take care of the patient, to the patient about the disease, allaying their fears, etc., as well as we are also communicating to the other interdepartmental collaborations, other members. We are teaching and we are communicating to everybody whom we come in contact with. Counselor, that is, stigma is associated with this, fear is associated with this. Here, the nurse plays a role as a counselor. When a patient is kept in an isolation where there is not, there are no attenders coming or family members coming, then the nurse may act as a counselor over there, where she will be able to talk to the patient, allay the fear and the stressors that the patient is facing. As an advocate, sometimes the patient may be in a state where he's not able to take decisions. So the nurse will play a role as an advocate. An organizer, how she plays a role as an organizer is in, starting from arranging the unit onwards, even till the patient is discharged. The nurse will play a greater role as an organizer in getting the things ready for the ward, in getting the staff ready for the ward, etc. As a manager, again, same thing will apply as an organizer and a manager. Even as an organizer, I could say that, implementing nursing process while we are taking care of the patient, assigning the roles to the different team members, all these are responsibilities and the roles of the nurse. As a health educator to the public, as well as for the peer group, as well as for the other members who are working in the hospital, like, maybe sanitary workers or the hospital aides or anybody else that she's coming in contact with. She is definitely playing a role as a health educator. Even at the time of discharge, she will be giving some information. She role as a health educator. Fact finder, definitely she finds the fact. While doing the history collection itself, she is playing the role of a fact finder. She will be able to get clues which she will be able to give to the other healthcare personnel, the doctors, etc., which will help in giving proper and the supportive care. And definitely a role of a coordinator. She coordinates with different members of the team to see that your patient is safe and patient is discharged home. Therefore, the roles of the nurse is not limited here. We have learned extended roles of the nurse also. The nurse is also member of, policy making and many other things which we are seeing at the INC level itself. Even this is the role of a nurse. And so nurses have a greater role to play in this COVID scenario in terms of case management. Thank you.
Thank you, Dr. Bindu. Can you unshare your screen? Thank you. It was a great learning experience, isn't it? I think the participants must be very happy to see what we have, how do we have, because yesterday we had hospital management, today it's a case management. How when the patient comes, how do we diagnose, how we screen them, how we triage them, and how at the end of the day, what is the role of a nurse? We have 10 different roles, isn't it? So let us applaud for ourselves that we have 10 different roles as a nurse, not only as a nurse, but as a 10 different roles. That is caregiver, case manager, communicator, counselor, advocate, organizer, manager, health educator, fact finder, and coordinator. Thank you so much, Dr. Bindu. So making us realize not only just a one word called nurse, but we have so many roles as a nurse. Thank you. Now we'll have Dr. Punita Izinarazu, who is backbone of the Indian Nursing Council. She has worked a lot on this webinar series, and now she'll be teaching you today. She was ex-dean of the CMC College of Nursing, and she's also a senior consultant with the Indian Nursing Council. She is be again telling you about the case management. She'll be telling more about the how do we go about the case management after till after the role of a nurse of the 10 different roles. Additional roles she'll be also telling about us. Okay, over to Dr. Punita.
Very good morning to all of you who have been listening for quite some time, Dr. Bindu's presentation. And I'm sure they are already overwhelmed with a lot of knowledge information. And I do have a number of PowerPoints to share. I would like to summarize some of them or highlight some of them. And before I start with the today's main focus on high-risk groups who require special consideration, how do you manage them, and also the care of the dead bodies. Before that, I just want to make you feel a little more relaxed by giving you some updates on what we have been hearing. What we heard on the first day and what we heard on the second time and third and fourth, there are some changes that is happening. So I thought I will just highlight some of those updates and move on to the high risk groups. And I know some of you might have read, heard, and shared some of these updates. However, to some of you, it might be the first time you are hearing. So I don't want to miss that opportunity. So I would like to tell you what are some of the updates on testing, the preventive measures that we are doing, the treatment, what's happening now, what are we moving forward. These are some of the things that I thought I will highlight on. The first thing that I would like to tell you is about the reuse of N95 mask in case of shortage. Every one of us are talking about reuse of N95 mask. Next slide, please. And this reuse of N95 mask, many of us are talking in terms of different people saying you can use it for so many times, you can't use this only once, it has to be done. But in shortage, what is, scientifically, with some scientific background, some reuse mechanisms have been suggested. This is by the emergency use authorization by the FDA, Food and Drug Administration of USA, and which is also acceptable by the ministry. It's called the Battelle decontamination system, that is the vapor-based phase hydrogen peroxide, which uses 11% hydrogen peroxide. And it says 20 times can be used after going through 20 decontamination cycles. It is not only the mask, also all the rest of the PPE. And if this is acceptable only if they observe the sporicidal and virucidal activity and filtration efficiency and breathability. And next, this particular decontamination phase, the AIIMS HICC has formulated the various guidelines, and they suggest a decontamination chamber very particularly for this, and people have been trained, sanitary workers have been trained separately to deal with this, and this exposure has to be 150-minute dwell time. And what they find, 5 calibrated chemical indicators that shows successful decontamination. But their guidelines also say this is used as a last resort when the shortage is very severe. But there are contraindications for decontamination, like visible soiling, damage of the mask, or any kind of a discoloration. And any materials which are cellulose of nature also cannot be used. And CDC also recommends this reuse and aims also using this, taking this as a guideline, and they also suggest this. And I found that in their guidelines, they say that every nurse is given a stock of 5 N95 masks, and each one can be used 5 times, which means all the 5 are placed at 5 brown covers. They pick up the first one and use it and put it back, keep it for dry, and they use the second day second mask, third day third mask, fourth day fourth mask, and then fifth mask is kept as a reserve, and they get back to the first mask from the brown cover, which is already dry, in rotation, which is placed in that. And this, they say, it can be used 5 times. That means it goes around rotation. So 20 times they can use it. So they need 5 masks for every staff, just to tide over the situation of the shortage, mainly reuse. And CDC also gives a recommendation about this particular. And also there is a solution given for reuse of face shield and goggles, that we immerse it into the 0.5% hypochlorite solution for 10 minutes and dry it on a surface which is cleaned by 70% alcohol, and it is used when it is dry. It is kept in a new container and it is used. That is for goggles and the face shields. And social distancing also, they say face-to-face contacts 6 feet with symptomatic COVID. And also they say contact more than 10 minutes to 30 minutes is not safe. And very recent publications which are published, some of the research reports which I read, it says the virus can hang in the air for hours and they can be infectious, and it can travel up to 8 meters, even during normal breathing or sneeze. So these are all very alarming findings that is coming up. So what we have seen earlier, it is slightly becoming different in the future after doing a lot of studies. But however, the new knowledge has to be evidence-based when it has to be put up as guidelines. And some of the, as you're talking about the signs and symptoms, the symptoms, before I look at that, recent paper they found in Spain, one research paper said there are bruising and lesions on the feet as symptoms. Signs and symptoms: bruising, lesions on the feet like chicken pox, and patients with COVID are exhibiting or demonstrating these kind of symptoms also, bruising and lesion signs, in Spain. And they also found some very atypical symptoms like skin marks, testicular pain, loss of taste and smell, headache, and dizziness. This also they found in Spain and as well as in China. So that is something new coming up. People are having like chicken pox like symptoms also while they are going through this infection. And some new recommendation by IMA, they said the testing has to be done for all healthcare workers. It is only a recommendation. It is not said, because we started with only symptomatic people. For testing is only for the symptomatic people, and then we moved on with high risk people. And IMA is saying all health workers are high risk people, you test them, all of them you test them. And they want to suggest studies should be done on prevalence of COVID-19 among healthcare staff using the rapid antibody test. Only then we will know what is the prevalence. So let us do some study on prevalence and using the rapid antibody test, which will show already they are infected, they are asymptomatic, but they have developed antibodies and they are developed immunity also. So the prevalence can be identified. And they also suggest adult vaccination against pneumonia, flu, especially for elderly. They say it is a must to minimize the severity, because we find that this vaccination, again, there is a lot of controversial issues in terms of BCG vaccination. More towards positive effect of the BCG vaccination, some studies, correlational studies, have said there is a relationship between BCG vaccination and reduction of prevalence of COVID-19 infection. So most rigorous studies are required with clinical trials to say there is scientific evidence to say that those who receive BCG vaccination will not, they are more immune to even COVID-19. And recently the advisory, Ministry of Health advisory, they said the rapid antibody test has to be done for clusters or containment zones and large migration gatherings. That is very important. It's the latest advisory issued by our Ministry of Health. Now the treatment options, all of us know there is no, the specific therapy, no specific antivirals, and many drug trials are in progress. Next, please. And some of the other treatment options that are available for specific conditions. One is colchicine antimitotic drug. This is being used for kidney transplant patients with COVID, and they are found to have recovered. This is seen in Italy and US. And another treatment option suggested, recommended by FDA US, is a blood purification device to treat 18 years of age or older admitted in ICU with imminent respiratory failure. Here, this decreases the cytokines and other inflammatory mediators. The next one is about adjunctive therapies, where the corticosteroids, systemic ones, are for treatment of viral pneumonia, but it is also warned that it should not be used routinely. And glucocorticoids also can be used for a short period of time, and the dose should not exceed 1 to 2 milligrams per kg per day. And if they are prescribed, careful monitoring has to be done to treat hypoglycemia, hypernatremia, and hypokalemia. Then there are co-infections. If there are any co-infection, the kind of treatment could be empiric antimicrobials to treat the specific pathogen. And this should be de-escalated on the basis of microbiology results and clinical judgment. Now, there are several drugs that are in trial. They are potential COVID-19 therapeutics. They are all currently in development. And remdesivir, you know, it is antiviral activity. They have found it in vitro against SARS-CoV-2, and it's an investigational drug. So it is outside the organism. They have done in outside cell culture. They found there is a antiviral activity. The same way, lopinavir and anti-HIV drug and chloroquine phosphate and hydroxychloroquine. This is authorized by FDA, emergency use authorization as treatment option or prophylaxis. And here also we know that the administration of lopinavir, where it is given, the criteria is given: symptomatic patients with hypoxia, hypertension, and any organ dysfunction. And if they have one or two of the below mentioned symptoms, they are given this drug. And then high risk groups, next one, the high risk groups, if they are elderly, age above 60 years, next slide please, who have comorbidities like diabetes mellitus, renal failure, and also chronic lung disease and immunocompromised persons. And the dosage that have been tried is 2 tablets twice daily, 200 milligram. And the duration is 14 days of 7 days after becoming asymptomatic. The next is the drugs recommended by CDC and ICMR, which we already heard. The next slide, please. which we have already heard yesterday. And Dr. Dilip also has been adding on to this particular information that for healthcare workers, this is recommended as prophylaxis and hospitalized patients. The hydroxychloroquine, the dose is 400 milligram BD for 1 day, followed by 200 BD for 4 days, and azithromycin 500 OD for 5 days, and under close monitoring, including QTC interval. Remember why monitoring of QTC interval is very important, because this drug can cause QT prolongation, and it will cause cardiac arrhythmias, and it is life-threatening too. So people who have cardiac disease, one has to be very careful to administer hydroxychloroquine, because it is contraindicated when anybody has got QTC interval prolongation. It is a corrected QT interval, because it can cause arrhythmias. And it is not recommended for children less than 12 years and those who are pregnant and lactating women. And next, the other therapeutic option under trial is in Australia, scientists have found that single dose of ivermectin can stop the growth of COVID in cell culture. This has been an approved, FDA-approved anti-parasitic drug. And other systemic interferons, which have been used to treat multiple sclerosis, is also tried now to treat COVID-19. Then monoclonal antibodies also under trial, and use of convalescent plasma for treatment. Yesterday we did mention that, and this convalescent plasma is being transfused because it has antibodies against the virus, which are given for severely ill patients, those who are in critically ill. Now this is being done as a clinical trial in many states, and Kerala is doing mainly on critically ill, and ICMR has approved some of the clinical trials by the different groups of people in different states. And next, a word about vaccine. No specific vaccine has been developed until today, and various trials are going on. And everybody says that scientists in different countries say it will take at least 1 year. And BCG vaccine, they also believe that it has some correlation, and those who have get good, the immunity what they get is also useful for COVID infection. So I said that it needs a lot of rigorous studies, and still studies are going on. Now moving on to the high risk groups, but first one is about the pregnant woman and newborn. There are limited data available on the perinatal outcomes. No evidence on mother to child transmission. There is no evidence till today, but there is a recent article which shows that the vertical transmission is also probable, although there is no evidence. So there is no correlation between the mother having COVID, and no evidence as such, and the infants also, newborns also having COVID. However, it was reported it could be probable, but normally there is no scientific evidence until today. And if you consider the asymptomatic transmission of this COVID in mothers or in pregnant people, all the women with epidemiologic history of contact should be very carefully monitored. And the important measures to prevent COVID infection in pregnancy, what are measures you need to tell them? Social distancing is the single most important, and follow the 5. This is the FOXI, talks about these follow the 5s. One is staying home, hand hygiene, respiratory hygiene, avoiding touching face, and keeping the distance. These are the 5 important aspects we must teach the pregnant women. And these pregnant women, what is a kind of clinical presentation? Do they have a different presentation? Next slide. They have, usually it is found that they have mild symptoms and they have the same course as other adults. And testing, quarantine, notification, all are same, and also prioritize prioritizing whenever they come to the hospital, any point of care, the testing priority is first for pregnant women because they belong to the high risk group. And arrangement in separate place for health facility to take care of all these pregnant women, and restriction of visitors in the health facility. Only one asymptomatic birth attendant is allowed, and use of mask by the visitor and family member is recommended. The pregnant women with suspected, probable or confirmed infection should have access to women-centered, respectful care, because this is a right of the pregnant women, and mode of birth can be individualized, and there should be multidisciplinary consultation and collaboration in providing obstetric and neonatal care for pregnant women and newborn. And we hope to arrange another series of webinars only for pregnancy and COVID, and therefore I limit to important aspects. The rest of it, if starting from antenatal, intrapartum, postnatal, and emergency obstetric care, and family planning, all those things are going to come separate series. So I don't go in depth. However, some of the important aspects I would like to cover. Next slide. And pregnant women who have recovered should be provided adequate information and counseling on safe infant feeding and IPC measures, and their choices and rights to sexual reproductive health care should be respected. Then a few words about breastfeeding. Next. The breastfeeding is effective against infectious disease and strengthens immunity, and it should be initiated within first hour of birth, and exclusive breastfeeding should continue for 6 months. And it is said there is no evidence of having transmission from mother to the baby through breast milk. And all the confirmed mother can breastfeed, but should follow respiratory hygiene using mask, hand hygiene, disinfection of surfaces. Every time before and after handling the baby, the mother should use hand hygiene. Strictly follow hand hygiene and also use mask while feeding. And breastfeeding counseling and psychosocial support and feeding support should be provided. And in severe illness, mother and the baby can be separated, and mother should be encouraged to give express milk and safely provide breast milk to the infant. And if unable to express, donor milk or breast milk substitutes can be given. Now, a few words about the elderly and COVID. The high risk group elderly belongs to the high risk group because they have decreased immunity and they have comorbidities, and the course of disease could be severe and result in high mortality. And the suspect cases, person-centered assessment and care should be given, and normally they have a greater risk of polypharmacy and lack of care coordination, and so interdisciplinary coordination is very important in taking care of them, and always involve caregivers and family members in decision making and goal setting. The Ministry of Health, government or the government of India, they gave an advisory for care of the elderly, which talks about so many do's and don'ts. Okay, and this advisory is available, and these are reiteration of already what we have said, how to educate the public and how to take what are the infection prevention precaution for the public, and that is do's and don'ts for the care of elderly is given in the Government of India advisory. The next, there are some other risk groups available. They are immunocompromised, and they are people who are on dialysis, those who are on chemotherapy, and chronic neurological diseases. So these are some of the specific risk groups that we have looked at it, and particularly the women, pregnant women, that the pregnancy and COVID will be dealt very much in depth later on. Now, moving on to another very important aspect, it's the care of the dead. Some of the important key considerations should be that the virus predominantly affects only the lungs. So the transmission possible is during autopsy only, not otherwise. Other than that, it is the contact precautions where if the surfaces are infected. And mainly it's a droplet for mites close contact, and there is no evidence of anyone dying because of the contact with the dead body. Next, other few considerations are safety, well-being of everyone who handled the body is first priority, and everyone should be well trained, and the dead dignity, cultural and religious traditions and families should be respected. Hasty disposal should be avoided. And there are few, these are all the care of the dead under various headings is given by the government of India guideline. These are all our national guidelines, which is very specific. It is available in the website, and everywhere you will find what are the various national guidelines in care of the dead. So I will highlight few of them under each one of the headings, like body removal from isolation room. What is more important is standard precautions, handling the tubes, how you remove them, disinfect the puncture wounds, and with 1% hypochlorite, and cover them impermeable material, and plugging off all the orifices for every dead body to prevent leakage. Next, and viewing of the dead body by family member allowed with application standard precautions, no kissing, no touching, and dead body has to be placed leak-proof plastic body bag, and exterior of the body bag can be disinfected by hypochlorite, and the body can be wrapped by mortuary sheet, or usually the family member will give sheets and can be wrapped and can be handed over to relatives or to the mortuary. And every state has issued certain guidelines to follow how to care for the dead, how to prepare the body, all based on the national guidelines, and how to take care of soiled linen, how to take care of equipment, how to take care of medical waste, and also use of PPE, and what are some of the counseling aspects are included when the body is removed from the isolation room. Next slide. And the people who are handling should wear PPE, very important, full complement, and the body is stored in cold chambers at 4 degrees centigrade, and the mortuary has to be kept clean, and environmental services, instrument, transport trolley, all that to be disinfected, and after removing again, whatever is remaining had to be disinfected. The chamber door, the handles, the floor, everything had to be disinfected. Next, a few words about embalming or autopsy. Embalming is not allowed, and autopsy is done only in special conditions where only well-trained who is in IPC practices, that team only will do this autopsy, and the forensic group, and number of team members should be limited, and they all should wear the full complement of PPE. And the next, only one body cavity open at one time, and negative pressure to be maintained in the mortuary. Yesterday we spoke about the negative pressure in ICU, and reduce aerosol generation during autopsy, because when they are handling the lung tissue, one has to be extremely careful. And needles also, use of shocks should be carefully done using standard precautions. The next, all the rest of it is in relation to the environmental cleaning. Before that, the body, after the procedure is disinfected, placed in the bag, and exterior clean, and handed over to the relatives, and autopsy table to be disinfected. And the environmental cleaning and control, we have already dealt with it earlier. What are the environmental cleaning precautions to be taken, what to be used, the same principles and the same disinfectants to be used for environmental cleaning, because it is also seen surfaces, sometimes it can stay, virus can stay up to 9 days, but studies have reported up to 72 hours in the experimental conditions. Next. This again, I don't want to go in because already the environmental condition, cleaning is already spoken early, the disinfectants. Next. Burial. I'd like to go on to the burial because this can be done buried or cremated. There is a misunderstanding or a myth that the body has to be only cremated. No, it can be buried or cremated. The same way as any infectious body, this also will be done. So there is no special fear or anxiety in relation to burial, and there are state local requirements. Body can be viewed by unzipping the face end of the body using standard precautions, and no touching and no kissing, and the staff will practice all the standard precautions. And washing of hands after removal, with soap and water, has to be done once the burial is complete, after removal of the gloves. And this is one important aspect I want to emphasize. The ash does not pose any risk and can be collected to perform last rites. In cremation, the ash does not pose any risk, and no large gatherings for any burial or at the crematorium. Social distancing has to be. Think now what they allow for any burial is maximum of 20 people for any funeral. That's why the local state government says, I'm not sure about other, but normally it is maximum of 20 people are allowed. Now, when it happens in the family or at home, the belongings should be handled with gloves and disinfected with 70% ethanol or 0.1% bleach. And the clothing should be machine washed with warm water, 60 to 90 degrees, or soaked in hot water, then in 0.5% chlorine or bleach for 30 minutes and laundried and dried in sunlight. So this is the way that even COVID or symptomatic or COVID positives, when they go back or when they are treated at home with mild symptoms, their clothing and belongings also can be done. So if anybody dies at home, this is how their belongings and their clothing can be disinfected. These are the important highlights, and I urge you to go and look at the Ministry of Health guidelines or the government guideline in caring for the dead. All these are given in detail. I think with this, I stop because already it is a very long session, and thank you for the opportunity, and also thank you for your patient listening.
Thank you very much, ma'am. It was a great learning. I mean, especially the care of the dead, which there were a lot of questions coming over. I think we are running short of time. The question and answers, we'll post it as an FAQ because already 12:30, and I think we should go as an FAQ. Present, sir?
I think some of the people may be having an anxious that the maternal and child health, the component, as Dr. Punita mentioned, that we are going to have a separate webinar. And also Indian Nursing Council is fully seized of the issue. This material, what we are doing this present webinars are good for the learning for the students and also faculty. So we are going, as already Bharti has mentioned daily, that it will be converting this into YouTube, and we'll be placing, we have already placed some of the YouTubes in our INC website. So we request all the faculty and also the students, especially final year students final year students of the GNM, the post-basic BSc students, and the MSc nursing students. They should be get refreshed, because at any point of time, your state governments may call you for a emergency duty. So therefore, we expect the faculty to motivate all the post-basic BSc students and the MSc students to be thorough with these protocols, and they may be called at any time for an emergency duty. The other some of the information which we would like to give was that we request the faculty, whichever in some of the private institutions where some of the staff nurses might be available there in the staff nurses who are working in the ICU or who are working in the postpartum or post-operative wards. Please motivate them to attend these webinars, because that will be useful, because at any time some of the private institutions, the state government may be using for the COVID patients. So therefore, we request the senior principals of the schools of nursing and colleges of nursing, especially who are having attached hospital, parent hospital, they should motivate and in case any in future, if the staff nurses are attending, please send us how many staff nurses from the particular institution have participated in this webinar. This information will be useful for the passing to the Ministry of Health, Government of India. So thank you very much.
Thank you very much. Tomorrow we'll be again coming back at 11 a.m. with ventilator management. So I request all the participants to log on at 10:45, 10:50, because Indian Nursing Council is very punctual in starting. So we start exactly at 11 a.m. So if you join before, so you can join from the starting itself. So thank you very much. See you tomorrow at 11 a.m. Namaste.
Thank you, ma'am. Thank you, sir. Thank you, ma'am. Thank you, everyone.
Thank you all.